Hi everybody, and welcome to our module on antihypertensives. In this video we're going to talk about drugs used to treat high blood pressure, and an easy way to understand the mechanisms behind all of these drugs is to remember that your blood pressure is determined by a combination of your cardiac output and your total peripheral resistance. Therefore, drugs that lower the blood pressure will work by either decreasing the cardiac output or decreasing peripheral resistance. There are two ways to lower the cardiac output. You can directly blunt the cardiac activity by decreasing heart rate or decreasing contractility, and some blood pressure pills work through this mechanism. You can also decrease the cardiac output by decreasing the circulating volume, and drugs like diuretics work in this manner. The main way that peripheral resistance is modified is by decreasing the vascular tone. So for example, drugs that are vasodilators will lower the total peripheral resistance, and that will be effective in reducing the blood pressure. The first class of antihypertensive drugs we're going to discuss are the beta blockers, and to understand these drugs we need to review the role of beta receptors in the autonomic nervous system. Recall that there are two types of beta receptors, beta 1 and beta 2. The beta 1 receptors are found in the heart and in the kidneys. In the heart, activation of beta 1 receptors leads to increased heart rate and contractility. In the kidneys, activation of these receptors stimulates renin release. Therefore, if you block the beta 1 receptors, you will have a fall in cardiac output and a decrease in the effective circulating volume, and this will lead to a fall in blood pressure. Beta 2 receptors, on the other hand, are found peripherally, especially in the muscle and liver, and in those systems they dilate blood vessels. They're also found in the lungs, where activation leads to bronchodilation. So if you block beta 2 receptors, in general, this does not lead to lower blood pressure, and it's not helpful for treating hypertension. With that in mind, let's go through the different beta blockers. Each of them is selective for either beta 1 receptors, beta 2 receptors, or both. We'll talk about the drugs that are beta 1 selective antagonists first. Drugs in this class include atenolol, metoprolol, and esmolol. All of these drugs can be used for hypertension. As we just discussed, they lower the cardiac output and the effective circulating volume and lower the blood pressure. Metoprolol is special. It's unique in this class in that it's used for systolic heart failure. It's effective in this condition because it blocks sympathetic stimulation of the heart, and I talk about this in greater detail in the heart failure videos. Metoprolol has been shown to reduce mortality, and that's why it's used for systolic heart failure. Atenolol and esmolol have not been tested and shown to reduce mortality in systolic heart failure, and therefore they are not used. Our next class of beta blockers are those that block the beta 1 and beta 2 receptors. These are said to be non-selective antagonists. Drugs in this class include propranolol, timolol, and naudolol. These drugs can be used for hypertension, although they really aren't anymore because we have much better options. Propranolol was one of the first beta blockers on the market, so years ago it was commonly used for hypertension. Naudolol and propranolol are used in the modern era very commonly, however, for portal hypertension in patients with cirrhosis. The reason they're effective in this condition is because the beta 1 blockade leads to a decrease in cardiac output and effective circulating volume. That lowers the blood pressure generally, including in the portal system. However, as I told you before, beta 2 receptors increase flow to the liver. So when you block beta 2 receptors, you have decreased portal blood flow, and this lowers the portal pressures. This makes these non-selective blockers very effective in portal hypertension, and that's one situation where you'll see them used clinically in the modern era. Timolol is often given as eye drops for patients who have glaucoma. The reason it's effective in this situation is because beta 1 and beta 2 receptors are both found in the eye. Stimulation leads to aqueous humor production, which raises intraocular pressures. So if you block the beta 1 and beta 2 receptors with timolol, you lower the intraocular pressures. There are some beta blockers which block beta 1 and beta 2 receptors but also block alpha 1 receptors. Alpha 1 receptors lead to vasoconstriction, so if you block alpha 1 receptors, you get a fall in peripheral resistance and a decrease in blood pressure. Drugs in this class include carvedilol and labetalol. Labetalol is often used in hypertensive emergency. When patients have dangerously high elevations in blood pressure, you can give labetalol intravenously, and it will result in a rapid reduction in blood pressure. Part of the reason it's so effective is because in addition to blocking the beta 1 receptors, it also blocks the alpha 1 receptors. Carvedilol, just like metoprolol, is used in systolic heart failure to block sympathetic stimulation of the heart. The reason this drug is used in systolic heart failure is because clinical trials have shown that it reduces mortality just like metoprolol. It's not because of a special feature of which receptors it blocks, it's because it's been studied in clinical trials and shown to be effective. That's why it's used in systolic heart failure. There are two beta blockers that have very unusual properties. They are called partial agonists. The two drugs in this class are pindolol, which is a non-selective beta blocker. It works on both beta 1 and beta 2 receptors, and acebutolol, which is beta 1 selective. Both of these drugs have what's known as intrinsic sympathomimetic activity. This means they function as beta agonists when the sympathetic nervous system activity is low, and they function as beta blockers when the sympathetic nervous system activity is high. Basically, they very mildly activate the beta receptor, so if you use them in a setting where sympathetic nervous system is high, they will activate it to a lesser degree than the nervous system does, and therefore they will lower the level of beta activation. The problem with these drugs when they used to be used for hypertension many years ago is that because they activate beta 1 receptors, they can cause angina in patients who have chronic stable angina. And in the section on basic pharmacology, I talk about the pharmacologic properties of these drugs. Because they are partial agonists, they have very unusual pharmacologic properties. Let's talk about some of the side effects that can potentially occur with any beta blocker. First, we'll talk about fatigue, erectile dysfunction in men, and depression. These are side effects that have always been attributed to beta blockers by virtue of the fact that they blunt central nervous system activity. These side effects are more common with older drugs like propranolol. They're less common with newer beta blockers. And you should know that all of these side effects have been called into question. Many patients with hypertension have these issues even when they're not taking a beta blocker. It's not clear that the beta blocker necessarily causes the symptom. Beta blockers can also cause a very mild hyperlipidemia. This is usually not clinically relevant. There's a mild increase in triglycerides and a slight decrease in the good cholesterol HDL. The effect varies with the different types of beta blockers. In clinical practice, we routinely give beta blockers to diabetics because these drugs have many benefits in this patient population. But you have to be cautious when you do this because beta blockers can potentially precipitate hypoglycemia. Diabetics are often vulnerable to hypoglycemia because they take medicines like insulin or other oral drugs that lower the blood sugar levels, and beta blockers can make this problem worse. One of the reasons for this is because beta blockers blunt the effects of epinephrine, and as you may know, epinephrine raises blood glucose levels, so when you block epinephrine, you can potentially cause hypoglycemia, especially in a diabetic who may be taking insulin or another drug that also lowers the blood sugar level. Another problem is that the symptoms of hypoglycemia are often masked in diabetics who are on beta blockers. When patients who are diabetic and are taking insulin become hypoglycemic, they often have an outpouring of sympathetic nervous system activity. So they develop symptoms like sweating, their heart will race and pound, they can develop tremors. Many of these symptoms are mediated by beta receptors, so the symptoms will be masked or blocked in a patient on a beta blocker, and therefore the patient will not recognize that they are hypoglycemic until they have a seizure from low blood sugar. The one exception is sweating. Sweating, as you may know, is mediated by muscarinic receptors, not beta receptors. So therefore, patients on beta blockers will still sweat when they are hypoglycemic, but other symptoms like their heart pounding and tremors will not be present, and therefore this can potentially be dangerous. You also have to be cautious using beta blockers in patients with reactive airway disease like asthma and COPD. Remember that the beta 2 receptors are bronchodilators, so if you block those receptors, you can cause a flare of COPD or asthma. For this reason, beta 1 blockers are often used in patients with these conditions. The beta 1 blockers are called cardioselective because they don't affect the lungs. You also have to be careful administering beta blockers to patients with decompensated heart failure, and the key word is decompensated. Patients who have pulmonary edema and are very sick from heart failure can get worse if you give a beta 1 blocker which lowers cardiac output. You should be aware, however, as I just told you, that metoprolol and carvedilol are commonly used in compensated heart failure. They have very powerful mortality benefits, so you want to give these drugs. You just don't want to give them to the patients when they're sick with pulmonary edema and other signs of acute heart failure. Rarely, patients can overdose on beta blockers. This is sometimes because of a suicide attempt. It can also sometimes happen if an elderly patient confuses their medications. If the amount of beta blockade is severe, it can result in depression of myocardial contractility and shock. It can also lead to bradycardia and AV block. The treatment for beta blocker overdose is peculiar. This is not anything intuitive. This is just something you have to know. The treatment is with glucagon. You may know that glucagon is secreted by the pancreas to raise the blood sugar level. In the setting of beta blocker overdose, however, it's administered intravenously for a reason that has nothing to do with blood sugar levels. The reason glucagon is effective in beta blocker overdose is because it stimulates myocardial cells at a different site from the beta receptors. Just like beta agonists, glucagon will activate adenyl cyclase, but it works at a different site from the beta receptors, which are all blocked down by overdose of the drug. This leads to a rise in cyclic AMP and a rise in intracellular calcium, the same effect as beta agonists. That will increase contraction and heart rate. In other words, you are stimulating the myocardial cells and bypassing the beta receptors, which are all blocked down by the overdose of the drug. Our next class of drugs is the alpha-1 blockers. Drugs in this class all have names that end in osin, like tamsulosin, doxazosin, terazosin. Recall that the alpha-1 receptors in the periphery lead to vasoconstriction. So when you block these receptors, that leads to vasodilation, which lowers the TPR and lowers the blood pressure. The main clinical use of these drugs is not so much to treat hypertension, but to treat BPH in men, which is benign prostatic hyperplasia. I talk about this disorder in the reproductive section, but in this disorder, alpha-1 blockers are helpful because they relax smooth muscle in the bladder and prostate, and this will increase urine flow. A common side effect of these drugs is postural hypotension. This is a fall in blood pressure when you stand up that can lead to dizziness and syncope. I'll talk more about this side effect later in this video because it's common to many hypertensive drugs, but one of the classic classes of drugs to cause postural hypotension is the alpha-1 blockers. And then finally, a special note on tamsulosin. Tamsulosin is called uroselective because it predominantly blocks the subset of alpha-1 receptors found in the bladder and prostate. For that reason, it's very useful in benign prostatic hyperplasia, but it has less hypotension effect. So you can use it in men who have BPH but no problem with blood pressure, where you want to help the BPH but you don't want to lower the blood pressure. Next, we're going to talk about drugs that work on alpha-2 receptors, and in order to understand these drugs, we need to review the role of alpha-2 receptors in the central nervous system. Alpha-2 receptors are presynaptic receptors. They're found on neurons which release norepinephrine onto vascular smooth muscle to cause vasoconstriction. Norepinephrine feeds back on the alpha-2 receptors, and when the alpha-2 receptors are activated, the neuron releases less norepinephrine. What this means is that agonists to alpha-2 receptors are effective antihypertensive drugs. They trick the neuron into thinking it has released too much norepinephrine. As a result, the neuron releases less norepinephrine and there's less vascular smooth muscle contraction. This leads to a lowering of the blood pressure. There are two drugs that are alpha-2 agonists. The first one is clonidine. This is an old drug that's rarely used in the modern era. Years ago, when it was one of the only drugs available, it was given sometimes in high dosages to treat hypertension. A key side effect of this drug is rebound hypertension. If patients abruptly stop taking their drug for any reason, especially if they were on a high dose, they could develop what's called rebound hypertension. Their blood pressure would get markedly elevated. The systolic could get over 200. The diastolic could also get over 120. They would also develop symptoms from the high blood pressure, but also from sympathetic nervous system overactivity. So a classic presentation, if you were a doctor in the 1960s when this drug was used, is that a patient on high dose of clonidine would suddenly stop their drug by accident and then present with nervousness, sweating. This is all from sympathetic nervous system overactivity. They'd also have a headache and chest pain from the high blood pressure. Another side effect of this drug is sedation. In my career, I've seen a small number of patients who needed to take this drug, and these patients would get very, very sleepy. This is because you're blocking sympathetic nervous system in general, and the patient gets very fatigued and tired. Sometimes they sleep a lot. The other alpha-2 agonist drug is called methyldopa, and the niche for this drug is that it's safe to use in women who have hypertension during pregnancy. Just like clonidine, it can cause sedation, and a special side effect of this drug is that it can rarely lead to a hemolytic anemia. It causes a warm autoimmune hemolytic anemia, and I talk about this in more detail in the hematology section. Our next class of antihypertensive drugs are the calcium channel blockers, and there are three major subclasses of calcium channel blockers. The first group are the dihydropyridines. Drugs in this class have names that end in apine, like nifedipine. Second group are the phenylalkylamines. Drugs in this class include verapamil. And the final group are the benzothiazepines, and drugs in this class include diltiazem. And all of these drugs function as vasodilators and negative chronotropes and inotropes, meaning that they decrease heart rate and contractility in the heart. The three classes of calcium channel blockers differ in their physiologic effects. In terms of vascular smooth muscle effects, meaning the vasodilatory effects that lower peripheral resistance, those effects are greatest for nifedipine and the dihydropyridine drugs. They are least for verapamil, and diltiazem is in the middle. On the other hand, in terms of heart rate and contractility effects, the greatest effects are seen with verapamil, the least with the dihydropyridines like nifedipine, and once again diltiazem is in the middle. Clinically, the way these drugs are used is the dihydropyridine drugs like nifedipine are used as vasodilators. Their main effect is to lower peripheral resistance, and they're mainly used for hypertension. The other drugs, the non-dihydropyridine drugs, are similar to beta-1 blockers. Their main effects are to lower heart rate and contractility, and therefore these drugs are often used in situations where you want to slow the heart rate. We'll talk about the dihydropyridine drugs first. As I said before, these drugs are used for hypertension because they are vasodilators that lower peripheral resistance. These are very effective antihypertensive drugs. You will commonly see them used clinically. Most patients tolerate them with no side effects, but when side effects do occur, they can be for one of two reasons. The first are the side effects related to vasodilation. So some patients experience flushing or headache or hypotension. This is all related to peripheral vasodilation. The second side effect, which is unique to this class of calcium channel blocking drugs, drugs is peripheral edema. This is a picture of a patient with lower extremity pitting edema, and this can occur on patients taking dihydropyridine calcium channel blockers. The reason for this is increased capillary hydrostatic pressure due to pre-capillary arteriolar vasodilation. Let's imagine we have a patient who is not taking a calcium channel blocking drug and they have a mean systemic pressure of 100. That patient will have an arteriole before their capillaries, which is constricted. That's what arterioles do. They're resistance vessels and they're often constricted. And because of the constriction on the pre-capillary arteriole, the pressure leading into the capillary will be 50. In other words, there's a pressure drop from 100 to 50 going across this pre-capillary arteriole. This leads to a hydrostatic pressure of 50 in the capillary, driving fluid out into the tissue. Now let's imagine that we administer a dihydropyridine calcium channel blocking drug. These drugs preferentially dilate the pre-capillary arterioles. This will lower the systemic blood pressure to a mean pressure of 80. That's good. That's the effect we want. We want the systemic blood pressure to fall. However, because the pre-capillary arteriole is dilated, there is less of a pressure drop going across this arteriole. What this means is the hydrostatic pressure feeding the capillary has now risen to 60. So in other words, we've lowered the systemic blood pressure, which is a good thing, but we've raised the pre-capillary pressure because we've dilated the pre-capillary arteriole. This means there is now a pressure of 60 driving fluid out of the capillary. That's higher than the pressure of 50 we had before. This means we have increased capillary hydrostatic pressure, and this causes edema. This is the mechanism of edema formation in patients taking dihydropyridine calcium channel blocking drugs like nifedipine. The other calcium channel blocking drugs like verapamil and diltiazem, predominantly slow the heart rate and decrease contractility. They function similar to beta-1 antagonists, as I said before. These drugs can be used in hypertension because they'll lower the blood pressure, but they're more often used in heart disease. They can slow the heart rate in patients with arrhythmias like atrial fibrillation. They can also lower the myocardial oxygen demand in patients who have stable angina. Because these drugs decrease contractility, a potential side effect is that they are negative inotropes, so in theory they can precipitate heart failure. Now, I've given these drugs to many patients with heart failure and they're usually well tolerated, but you do have to be careful because they can depress contractility. Other potential side effects of calcium channel blockers include constipation. You need calcium channels for normal gut motility. This most commonly occurs in patients taking verapamil. Calcium channel blockers can also rarely lead to a rise in prolactin levels. This is seen in patients taking verapamil. The mechanism is believed to be blockade of calcium channels in the central nervous system that leads to decreased dopamine release. And as you may know, dopamine inhibits the release of prolactin from the pituitary gland. So when the dopamine levels fall, more prolactin is released. This can cause hypogonadism, and the symptoms depend on whether it occurs in a man or a woman. In men, this leads to decreased libido and impotence. In women who are premenopausal, it can lead to irregular menses and galactorrhea. Another rare side effect of calcium channel blockers is gingival hyperplasia. This is a picture of a patient with gingival hyperplasia shown on the slide here. This can be seen in all types of calcium channel blockers. It also occurs rarely in patients taking two other drugs, phenytoin, which is a seizure drug, or cyclosporin, which is an immunosuppressant. Next, we're going to talk about a number of classes of antihypertensives that lower the level of angiotensin II. Anything that lowers the amount of angiotensin II in the body will lower the blood pressure. So to understand this, let's review the renin-angiotensin system. Angiotensinogen is synthesized by the liver and converted by renin into angiotensin I. In the lungs, angiotensin converting enzyme, or ACE, converts angiotensin I into angiotensin II. And angiotensin II has a number of effects that raise the blood pressure. First of all, it's a direct arteriolar vasoconstrictor. In addition, it activates the sympathetic nervous system. It also promotes renal sodium and chloride reabsorption. In addition, it can promote aldosterone secretion from the adrenal glands and ADH secretion from the pituitary gland. The net result is more salt and water retention, more preload on the heart, and more afterload, and all of these come together to raise the blood pressure. There are three classes of drugs that inhibit this system and lower the angiotensin II level. First of all, there are the ACE inhibitors, which inhibit the ACE enzyme and lower the amount of angiotensin II produced from angiotensin I. There are also angiotensin receptor blockers, which directly block the effects of angiotensin II but don't reduce the levels of angiotensin II. And then finally, there's one drug called aliskiren, which is a direct renin inhibitor. The ACE inhibitor drugs have names that end in pril, like captopril or lisinopril. The angiotensin receptor blockers are called ARBs. They have names that end in sartan, like candesartan or irbesartan or valsartan. Common side effects of ACE inhibitors and ARBs include hyperkalemia. Hyperkalemia occurs because decreased aldosterone levels develop in the setting of decreased angiotensin II effects. And then another common side effect of angiotensin II drugs like ACE inhibitors and ARBs is renal failure. This happens because the GFR can potentially fall when you blunt the effects of angiotensin II. To understand this, let's imagine that we have a glomerular capillary with an afferent arteriole and an efferent arteriole. Angiotensin II preferentially vasoconstricts the efferent arteriole. This raises the glomerular capillary pressure and drives fluid across the glomerular membrane into the nephron. In other words, angiotensin II, through vasoconstriction of the efferent arteriole, maintains glomerular filtration. If you block the effects of angiotensin II, this will vasodilate the efferent arteriole. This can potentially lower the glomerular capillary pressure to such a degree that GFR begins to fall and renal failure begins to develop. And that's the mechanism by which ACE inhibitors and ARBs can potentially lead to renal failure. ACE inhibitors have a couple of unique side effects that generally do not occur in patients taking ARBs, and those have to do with the molecule bradykinin. Bradykinin is an inflammatory mediator, and it's broken down by angiotensin converting enzyme into inactive metabolites. What this means is when you administer an ACE inhibitor, you get inhibition of the conversion of angiotensin I to angiotensin II. That's the effect that you want. That's the effect that's beneficial for hypertension. But an unintended side effect is that the levels of bradykinin will rise because ACE is inhibited, and that will lead to the side effects related to cough and vasodilation, which are caused by bradykinin. About 10% of patients taking ACE inhibitors develop a dry cough. This is related to increased levels of bradykinin. The other potential side effect due to high levels of bradykinin is more dangerous. That's angioedema. This results from the vasodilation triggered by bradykinin. This is swelling of the face and tongue, and it can potentially be life-threatening. This is a picture of a child who has angioedema of the face because of a bee sting. You can see that her eye is swollen. In patients taking ACE inhibitors, they can develop swelling like this, including swelling around the eyes, around the tongue, and in the back of the throat. And this can lead to life-threatening angioedema caused by ACE inhibition, leading to high bradykinin levels. Aliskiren is a direct renin inhibitor. It inhibits renin so that you get decreased production of angiotensin I, which leads to lower levels of angiotensin II. The thing you want to know about this drug for step 1 is that it reduces angiotensin I levels. This is a unique effect. When you inhibit ACE, you get lower levels of A2, but not lower levels of A1. However, when you inhibit renin, you are inhibiting the renin-angiotensin system further upstream. This means you will have lower levels of angiotensin I when patients take aliskiren. I talk about diuretics in detail in a video in the renal section. I won't discuss them here. I'll just mention that diuretics can be used to treat hypertension. The one diuretic that's commonly used to treat hypertension is hydrochlorothiazide. It inhibits sodium reabsorption in the distal tubule. Hydralazine is a unique drug for hypertension. It's in a class by itself. It's a direct arteriolar vasodilator. It's rarely used for hypertension. It's an older drug, not used much in the modern era. It's also sometimes combined with nitrates for patients with heart failure. The hydralazine will reduce the afterload, and the nitrates are venodilators, so they will reduce the preload, and this is helpful in patients with heart failure. Hydralazine is safe in pregnancy, so it's sometimes used in pregnant women, and it has a special side effect, which is that it can potentially cause drug-induced lupus. Drug-induced lupus is a syndrome similar to traditional lupus. It often involves a rash and arthritis and low blood cell counts. It's usually milder than traditional lupus, and importantly, there's usually no associated renal failure or central nervous system disease. These are the dangerous effects of traditional lupus. A key finding on blood work that's unique to drug-induced lupus is the presence of antihistone antibodies. And there are 3 drugs that can cause drug-induced lupus that you should know as a medical student. One is hydralazine, the other is procainamide, which is an antiarrhythmic, and the other one is isoniazid, which is a drug used to treat tuberculosis. The next few drugs we're going to talk about are used only in the setting of hypertensive emergency. Unique drugs are used in this situation. You need drugs that are intravenous and rapid acting. You also need drugs that have an effect that you can titrate carefully, because if you lower the blood pressure too fast, this can cause ischemia. Many of our vascular beds have what's known as autoregulation, which means they try to control the blood flow to tissues. When the blood pressure is very, very high, there's massive blood flow into these vascular beds, so they vasoconstrict to try and normalize the blood flow. If you suddenly take away that high blood pressure, you're left with tissue beds that are vasoconstricted, and they can become ischemic, and this can make the patient very sick. So you need to carefully titrate the medical therapy in the setting of hypertensive emergency. Nitroprusside is a drug that's commonly used for hypertensive emergency. It's a short-acting drug, so you can titrate the effect. It works on vascular smooth muscle to raise intracellular cyclic GMP levels and increase nitric oxide release. This results in vasodilation of veins and arteries. By vasodilating veins, the preload will fall because the venous return to the left ventricle will fall, and by dilating arteries, the afterload will fall. So both of these effects lead to lower blood pressure. Nitroprusside is only administered for short periods of time. That's because with prolonged use, cyanide toxicity can occur. Shown on the screen is the structure of sodium nitroprusside. All these CN groups are cyanide molecules, so you can see that there are multiple cyanide molecules per molecule of sodium nitroprusside. And cyanide, as you may know, inhibits electron transport, and high dosages are potentially fatal. So if patients are administered nitroprusside for prolonged periods of time, toxic levels of cyanide can develop and patients can become very sick. Usually we only use nitroprusside in the ICU setting for a few hours or maybe a day or so until we transition patients to oral therapy for hypertension. Phenoldiprem is another drug that can be used in the setting of hypertensive emergency. It activates a specific type of dopamine receptor called the D1 receptor. When this receptor is stimulated, it leads to vasodilation of arteries. It also leads to increased renal perfusion so that there is increased sodium and water excretion from the kidneys. Thus, the effect of this drug is that it will vasodilate, but it will also maintain renal perfusion and promote urinary output. Both of these effects lead to a lowering of the blood pressure. On this slide, I've listed some other drugs that can be used in hypertensive emergency. These drugs are in classes we've already talked about. Labetalol is a beta-1 and alpha-1 blocker, which will lower the blood pressure. Esmolol is a very short-acting intravenous beta-1 blocker. It can be used in hypertensive emergency. And nicardipine and clofidipine are intravenous dihydropyridine calcium channel blockers. They are also used in hypertensive emergency. Now that we've gone through all the drugs, I'm going to talk about two side effects that are common to a number of different blood pressure medicines. The first one is orthostatic hypotension. It's also called postural hypotension or orthostasis. Anytime you stand from a seated or lying position, your blood pressure drops because gravity pulls venous blood down to your feet and drops the venous return. This could make you dizzy and even make you pass out, but that doesn't happen because your body compensates with the sympathetic nervous system. The sympathetic nervous system, as you know, can increase venous return, increase cardiac output, heart rate, and also peripheral resistance. And all of these effects blunt the drop in blood pressure so that you don't get dizzy when you stand up. However, this response by the sympathetic nervous system is impaired in a number of settings. First of all, it's impaired when you have hypovolemia. It's also impaired if total peripheral resistance is very low, and it can be impaired if anything is blunting the autonomic nervous system. When one of these things is present and the response of the sympathetic nervous system is blunted, there can be a severe fall in blood pressure, more than 20 millimeters of mercury of systolic blood pressure. This is the definition of orthostatic hypotension, and it can lead to dizziness and syncope. And there are many etiologies of orthostatic hypotension, but two of the common ones are hypovolemia and hypertensive medications. Patients taking too many blood pressure pills can have their blood pressure get too low, and one of the symptoms that they will develop is orthostatic hypotension. It's common to all antihypertensive drugs. Now, any antihypertensive drug can cause orthostatic hypotension, but there are a couple of classes of antihypertensives that are classic for causing orthostasis, so let's talk about those now. First are the alpha-1 blockers. Your alpha-1 receptors are a very important part of the sympathetic nervous system response when you stand up, so if the alpha-1 receptors are blocked, this can cause orthostatic hypotension. A second classic scenario is in a patient who is administered an ACE inhibitor when they are already on a diuretic. When patients are taking diuretics, their volume depleted from the diuretic and their renin-angiotensin-aldosterone system is activated. This means they are dependent on angiotensin II to maintain their blood pressure. So if you administer an ACE inhibitor to a patient on a diuretic, they can become hypotensive. This classically occurs with the first dose of an ACE inhibitor given to a patient on a diuretic, and it's called first dose hypotension. Another effect that can potentially occur with many antihypertensives is reflex tachycardia. Any drug that works via vasodilation will lower the blood pressure, but this in turn will activate the sympathetic nervous system. This can lead to a reflex response where the heart rate rises. That's called reflex tachycardia. And this can be caused by any antihypertensive drug that works through vasodilation. It commonly occurs with hydralazine. It's also common after administration of alpha-1 blockers. You can also see it with dihydropyridine calcium channel blockers like nifedipine. It can also be seen with nitroglycerin when it's administered for heart failure. In patients who have chronic stable angina, this reflexive increase in heart rate can potentially exacerbate the angina. That's because it will increase the heart rate and raise the myocardial oxygen demand. And if you want, you can co-administer a beta blocker, and that will blunt this reflex tachycardia effect. The way you'll often be tested on antihypertensive drugs is by being shown a clinical scenario and then being asked which drug is the best choice for the patient or which drugs are contraindicated. So let's go through some of those scenarios now. In patients who have diabetes who develop hypertension, ACE inhibitors are often used. That's because there are data that ACE inhibitors are protective against diabetic kidney disease, so you treat the hypertension and also protect the kidneys. As we talked about in this video, beta blockers can lower glucose and mask hypoglycemia, so you have to be careful when using beta blockers in patients with diabetes. And then in the renal section, I talk about hydrochlorothiazide. It's a diuretic and it can produce a mild increase in blood glucose levels. In patients who have systolic heart failure, meaning they have a reduced left ventricular ejection fraction, ACE inhibitors, beta blockers, and aldosterone blockers have all been shown in clinical trials to have a mortality benefit, meaning they reduce the risk of death from systolic heart failure. So when patients with systolic heart failure need therapy for hypertension, these are the drugs that are often used. As I talked about earlier, calcium channel blockers like verapamil and diltiazem can reduce contractility, so you have to be cautious when using these drugs in patients with systolic heart failure. For hypertension that occurs in pregnancy, methyldopa is often considered the drug of choice. Beta blockers, calcium channel blockers like nifedipine and hydralazine can also be used. The key drugs to avoid in pregnancy are ACE inhibitors, ARBs, and direct renin inhibitors. All these drugs that interfere with the renin-angiotensin-aldosterone system are associated with congenital malformations of the fetus. And then finally, if you're faced with a patient who has significant renal failure or hyperkalemia, there's a long list of drugs you need to avoid. First of all, you want to avoid ACE inhibitors and ARBs. That's because they decrease angiotensin II and they can worsen renal failure, as we talked about earlier in this video. They also decrease the aldosterone level, and that can worsen the hyperkalemia. You obviously want to avoid potassium-sparing diuretics. These drugs raise the potassium level. You also want to avoid other diuretics because they lower the effective circulating volume and lower the GFR. Drugs that are often used in the setting of advanced renal failure or hyperkalemia are calcium channel blockers and beta blockers. Both of these usually have no negative effects on kidney function and they don't affect the potassium level. And that concludes our video on antihypertensives.